Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture, I will be going over disorders of aromatic amino acid metabolism, particularly phenylketonuria. Let's get into the details of phenylketonuria. Phenylketonuria is the most common inborn error of metabolism and it follows autosomal recessive inheritance pattern. So the defect is a mutation in a gene that is coding for phenylalanine hydroxylase enzyme, and the gene name is PAH gene, which is located on chromosome number 12. So phenylketonuria is commonly seen in Irish, Northern European, Turkish and Native American ancestry. There are 4 types of phenylketonuria. So phenylketonuria type 1 is generally referred as classical phenylketonuria, and this is because of complete absence of phenylalanine hydroxylase enzyme. And type 2 phenylketonuria is because of partial deficiency of phenylalanine hydroxylase enzyme. Type 3 phenylketonuria is because of deficiency of dihydropteridine reductase enzyme. And type 4 phenylketonuria is because of defect in the synthesis of tetrahydrobiopterin from guanosine triphosphate. So here is the pathway which I have explained to you in detail when I was going over conversion of phenylalanine into tyrosine and tyrosine further into fumarate and acetoacetate. Again, just to briefly going over the same pathway here, conversion of phenylalanine into tyrosine is done by phenylalanine hydroxylase enzyme, and the coenzyme for this enzyme is tetrahydrobiopterin. And with this, phenylalanine is hydroxylated to the phenyl ring to forming a phenol here, making tyrosine, while tetrahydrobiopterin is converted into dihydrobiopterin. Now the dihydrobiopterin has to be converted back into tetrahydrobiopterin so that the tetrahydrobiopterin pool need to be maintained, and that will be done by enzyme dihydropteridine reductase using protons coming from NADH plus H plus. And also, like any other coenzymes in our cells, so coenzymes are synthesized in limited quantities, so there must be a significant recycling process. So that is why we have a dihydropteridine reductase enzyme here. Now a new molecule of tetrahydrobiopterin can be synthesized by a multi-step process from guanosine triphosphate. So what will happen if there is an absence of phenylalanine hydroxylase or deficiency of phenylalanine hydroxylase? So if there is an absence or deficiency of phenylalanine hydroxylase, so there will be decrease in the conversion of phenylalanine into tyrosine. That means tyrosine levels will be decreased and phenylalanine levels will be increased. That's what happens in classical phenylketonuria or type 1 phenylketonuria because of absence of phenylalanine hydroxylase, or in type 2 phenylketonuria because of deficiency of phenylalanine hydroxylase. There will be rise in the phenylalanine levels in the blood and decrease in tyrosine in the cell. Now, if there is a defect in tetrahydrobiopterin reductase enzyme, that will lead to decrease in tetrahydrobiopterin coenzyme, and when there is a decrease in tetrahydrobiopterin coenzyme, that will also decrease the activity of phenylalanine hydroxylase, leading to increase in phenylalanine and decrease in tyrosine. So in phenylketonuria, note that tyrosine becomes essential amino acid, although in other conditions like normal individual, tyrosine is not an essential amino acid. So, defect in dihydropteridine reductase gives rise to type 3 phenylketonuria. Now, the defect in the synthesis of tetrahydrobiopterin from GTP will give rise to type 4 phenylketonuria. So, type 1 and type 2 is because of phenylalanine hydroxylase absence or partial deficiency. Type 3 is because of dihydropteridine reductase enzyme deficiency. And type 4 phenylketonuria is because of defect in the conversion of GTP into tetrahydrobiopterin. So in classical phenylketonuria, the phenylalanine hydroxylase enzyme activity will be less than 1%. Blood phenylalanine levels will be more than 16 milligrams per deciliter. And this excessive phenylalanine in the cell may be diverted into other phenylalanine derivatives. And the other fate of phenylalanine in the cell is phenylalanine, that is alanine there, is converted into phenyl pyruvate, and that phenyl pyruvate is converted to phenyl acetate upon decarboxylation, and phenyl acetate levels can be elevated in the blood and appearing in the urine. And the phenyl acetate is a phenyl ketone derivative. Phenyl pyruvate can be converted to phenyl lactate, and phenyl acetate further it might bind with the glutamine, becoming phenyl acetyl glutamine, and can also be found in the urine. So the phenyl ketone derivatives will appear in the urine. That's why the name of the disease is phenylketonuria. And also note that the presence of elevated levels of phenyl acetate in the body fluids, including urine, will give rise to a characteristic smell to the body fluid called mousy or musty odor, and that's because of presence of phenyl acetate at increased concentration. Coming to diagnostic tests for phenylketonuria, so the screening methods include ferric chloride test or GU3 bacterial inhibition assay test. So in the GU3 bacterial inhibition assay test, spores of Bacillus subtilis is used, and in the agar media, this Bacillus subtilis, it is mixed with the beta-2-thioalanine. So whenever phenylalanine levels in the blood is less than 4 milligrams per deciliter, so the spores do not germinate, because beta-2-thioalanine will have an inhibitory effect on Bacillus subtilis spores. When a phenylalanine levels in the blood exceeds more than 4 milligram per deciliter, at that time, see, the phenylalanine itself will have an inhibitory effect on beta-2-thioalanine, and thereby the inhibitory effect of beta-2-thioalanine on Bacillus subtilis spores is not there. That's when Bacillus subtilis will germinate and make colonies. So the presence of colonies in GU3 bacterial assay test is a positive sign for elevated levels of phenylalanine in the blood. Or otherwise, we can just measure phenylalanine levels in the blood, and we can do amino acid analysis using paper chromatography, where phenylalanine is elevated and tyrosine is decreased, which is a diagnostic point there. And microfluorometric determination of phenylalanine and HPLC based determination of phenylalanine can be done. Clinical presentation of phenylketonuria. The most important and most common clinical presentation with phenylketonuria is mental retardation. IQ be between 25 to 50, and neurological signs includes patients show hyperactive deep tendon reflexes and seizures. And also some of the patients may show fair skin and hair, resulting due to impairment of melanin synthesis. Why? Because phenylalanine conversion into tyrosine is decreased here, and one of the special product that is coming from tyrosine is melanin, and that melanin will be decreased. Now, other manifestations include like eczema, photosensitivity, increased incidence of pyogenic infections, keratosis pilaris, scleroderma like plaques. All these are the other skin manifestations in phenylketonuria. And one of the characteristic feature of phenylketonuria is musty or mousy odor to body fluids, and that's because of presence of increased levels of phenyl acetate. What is the treatment for phenylketonuria? Low phenylalanine diet is one of the key treatment for phenylketonuria, and low phenylalanine diet available are lofenalac or PKU aid, which is a special synthetic preparation where phenylalanine levels are decreased, tyrosine levels are maintained at optimal levels. So whenever phenylalanine levels are taken out of the food, so tyrosine must be supplemented because tyrosine becomes essential in phenylketonuria patients. Or any foods and soft drinks that contains artificial sweetener, aspartame, must be avoided in phenylketonuria patients because aspartame, it contains phenylalanine and aspartate. So consumption of aspartate may increase phenylalanine levels in the phenylketonuria patients. And one of the treatment that is tried in phenylketonuria patients is sapropterin hydrochloride, which is a synthetic form of tetrahydrobiopterin. So, providing tetrahydrobiopterin may improve phenylalanine hydroxylase enzyme activity in partial phenylalanine enzyme deficiency, that is type 2 phenylketonuria. There is an enzyme replacement therapy that is tried in phenylketonuria, and that you must remember, other than tetrahydrobiopterin supplementation, that is sapropterin hydrochloride, which is brand named as 𝐒𝐲𝐶. Other than that, there is a drug called 𝗫𝐲𝐴Lase. This 𝗫𝐲𝐴Lase is a polyethylene glycated phenylalanine ammonia lyase enzyme that substitutes for the deficient phenylalanine hydroxylase enzyme activity in phenylketonuria patients. So, 𝗫𝐲𝐴Lase enzyme you got to remember here as one of the specific treatment for phenylketonuria. Coming to little bit about maternal phenylketonuria. Expectant mother having phenylketonuria must maintain low phenylalanine levels before and during pregnancy, more specifically before conceiving and also in the first trimester of pregnancy, at least 8 to 10 weeks into the pregnancy. Failure to maintain low phenylalanine levels in a pregnant mother will result in a congenital anomalies in the baby. And the type of congenital anomalies that you may see in the developing fetus is congenital heart disease, growth retardation, small brain like microcephaly, and mental retardation. Coming to a variant of phenylketonuria called malignant hyperphenylalanemia because of deficiency of dihydropteridine reductase enzyme or defect in the biosynthesis of tetrahydrobiopterin from GTP, and this is grouped under type 3 and type 4 phenylketonuria. So as we have seen in the previous slide in the classification of phenylketonuria, I have explained to you defect in dihydropteridine reductase enzyme will give rise to type 3 phenylketonuria, and defect in the synthesis of tetrahydrobiopterin from guanosine triphosphate will give rise to type 4 phenylketonuria. So both type 3 and type 4 phenylketonuria are grouped under what is referred as malignant hyperphenylalanemia. Why it is said like that? So I would like to take you back to the slide here, where I have explained you if there is a defect or deficiency in dihydropteridine reductase enzyme. So that will lead to decrease in the conversion of dihydropteridine into tetrahydrobiopterin. So if there is a deficiency in tetrahydrobiopterin, it is going to decrease the activity of phenylalanine hydroxylase enzyme. Not only that, deficiency of tetrahydrobiopterin, it is going to affect many other enzyme activity in our cells. That is, tetrahydrobiopterin, it is a coenzyme for tryptophan hydroxylase, which is converting L-tryptophan into 5-hydroxytryptophan, and eventually that 5-hydroxytryptophan becomes serotonin and melatonin. Tetrahydrobiopterin is also necessary for the conversion of L-tyrosine into DOPA, because tyrosine hydroxylase enzyme also needs tetrahydrobiopterin here. So the L-tyrosine to DOPA, DOPA to dopamine formation, dopamine into norepinephrine, and norepinephrine into epinephrine. This is why you need tetrahydrobiopterin for tyrosine hydroxylase there. And also tetrahydrobiopterin is necessary for nitric oxide synthase for the conversion of arginine into nitric oxide. So the point here is tetrahydrobiopterin is not only required for phenylalanine hydroxylase, it is also required for tryptophan hydroxylase, which is involved in the formation of serotonin and melatonin, two neurotransmitters there. Tyrosine hydroxylase, which is involved in the conversion of tyrosine into dopa, and dopa to dopamine, norepinephrine, epinephrine, these three neurotransmitters. And also it is involved in the conversion of arginine into nitric oxide by nitric oxide synthase. So nitric oxide is also a neurotransmitter in the central nervous system. It is a vasodilator and also it is an immunomodulator. So point here is, if there is a defect or deficiency in dihydropteridine reductase enzyme, it will give rise to decreased activity of not only phenylalanine hydroxylase, is going to lead to decreased activity of other hydroxylases including nitric oxide synthase, leading to deficiency in the formation of many neurotransmitters including nitric oxide. So because of this, what will happen? Decrease in catecholamine synthesis, that is dopamine, norepinephrine, epinephrine, decrease in serotonin, melatonin, decrease in nitric oxide, all of them will lead to severe neurological manifestations. Particularly, decreased dopamine will lead to increased levels of prolactin, because normally dopamine will have an inhibitory effect on release of prolactin. So now when the dopamine is down, prolactin levels will increase. So that's something which is increased here. So dopamine is decreased, norepinephrine is decreased, epinephrine is decreased, serotonin is decreased, melatonin is decreased, but prolactin is increased. Remember that. So with all these changes, patients with malignant hyperphenylalaninemia, they will suffer from severe neurological issues and usually it will lead to death. Okay, it's not just about phenylalanine not converted into tyrosine, where phenylalanine level increases leading to phenyl acetate, phenyl lactate appearing in the urine, mousy odor, musty odor, all those signs you will see, but most importantly severe neurological issues because of deficiency of all these neurotransmitters will make malignant hyperphenylalanemia as a malignant disorder of phenylalanine metabolism. How to treat this? So treatment is as supplementation of 𝐒𝐴N, which is a sapropterin hydrochloride, is used as a treatment because 𝐒𝐴N stimulates the activity of residual phenylalanine hydroxylase enzyme in PKU patients who are BH4 responders to metabolize phenylalanine into tyrosine. Okay. So this is all about disorders are associated with aromatic amino acids, more particularly different types of phenylketonuria. Thank you.